So, hello everyone, and welcome to Ask Me Anything, Stay Sharp, Microplanning for the Flu and COVID-19 Vaccines, session number 7, our final in our series, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my colleague, Sarah Price, Deputy Director of Public Health Integration. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 30 minutes, including introductions and, of course, a live Q&A. Please note that the Q&A box is located in the lower right-hand side of your computer screen, open right now for you. So feel free to place your questions into this box. Simply type your question, make sure you hit all panelists, and hit send. Friendly reminders that today's event is being recorded and will be available online within 48 hours. All attendee lines have been muted and will be muted for the duration of this event. The Q&A box is open currently right now, so feel free to plug in all those questions for our panelists. And again, if we cannot answer your question in the time allotted or need additional resources, we'll make an attempt after the event is complete. And we also are developing an FAQ document that involves all 7 of our series with pertinent questions that would be relevant to the field. At this moment, I'm going to turn things over to Sarah, who will be introducing today's speakers and setting the stage for you. Sarah, the floor is yours.
Thank you so much. Thank you, Liz. I want to publicly thank her. As she said, this is our 7th episode, session, whatever we want to call it. And we had actually extended it because it was so popular. So this will be our last session. We are talking about other ways to share all the resources and innovations. And also, this is not the last that you'll hear from us, just the last in this format. So I want to thank Liz, especially for all of her support in doing this. Today, we are really fortunate to be joined by 3 speakers. Today, we've been featuring Claire Hannon with the Association of Immunization Managers. She was called away today, but we are so excited to have Carolyn Bridges, who's the Associate Director for Adult Immunization with the Immunization Action Coalition. So she's actually going to be sharing with us first. She is fresh from the yesterday's ACIP meeting. So she will tell us some really great updates on the different indications and some logistics surrounding the COVID-19 vaccine products. And then we'll move to Rhonda Arlene, who's the Director of Nursing for Albany Area Primary Health Care, as well as Shelley Spires, who's the Chief Executive Officer of Albany Area Primary Health Care. They're in Albany, Georgia. And we'll talk about the immunization practices that they've been doing for COVID-19 and give us some really practical tips. So throughout their presentations and through their talking, again, we encourage you to start putting questions into the chat. This is a great venue for that, and we want to be able to give them time to answer the questions that you put forth before them. So I'll turn it right now over to Carolyn to give us some information from the ACIP meeting. Carolyn?
Great, thanks so much. Let's get put on the first slide. So there have been a number of updates in terms of clinical considerations for using the 2 mRNA vaccines. One of those updates is that there obviously have been some concerns about the timing of that second dose. So CDC has clarified that if it's not feasible to adhere to the recommended interval for the second dose, so that's 28 days for Moderna and 21 ideally for Pfizer, that you can schedule the second dose up to 6 weeks or 42 days after the first dose. But importantly, if you do not get that second dose in within that time frame, still you do not repeat the dose and you just get the second dose as soon as you're able to. Next slide. They also had some updated information on interchangeability of these 2 vaccine products. And again, the recommendation is you want to give the same product for the first dose as the second dose. But if there is a situation that should be a rare situation in which the first dose vaccine product can't be found or it's no longer available, then you can give any available mRNA vaccine for the second dose and the minimum interval for that is 28 days. But ideally, this situation will be rare, but if you can't figure out which kind of vaccine, mRNA vaccine they got in the first dose, just give a second dose at 28 days or later. Next slide. Next slide. No, thank you. They also had some updated information on vaccination of people who've had a history of SARS-CoV-2 co-infection, and really just reiterated a bit more that if vaccine supply remains limited, that you can think about, again, delaying vaccination temporarily among people who've already had infection. So if supply is an issue, which of course it is all over the country right now, you may choose to delay vaccination for a while in people who have had a known SARS-CoV-2 infection. Next slide. There have been a lot of discussions at the ACIP meeting, as well as a lot in the news about new SARS-CoV-2 virus variants that are in circulation. There have been a number of reports in the news, and now some also publications. I provided a bunch of links there for people who really want to get into a lot of details. But both for the Pfizer and Moderna vaccines, they're reporting that there may be some modest reduction in antibody titers against particularly the South African strain, but they do expect that these vaccines will still provide substantial protection against that South African strain. For Novavax, they also had a press release and a new report that's in a non-peer-reviewed publication at this point. Again, the link is there. So the Novavax vaccine is in phase 3 studies right now in the U.S. and in Mexico, but they did provide some information again about efficacy against these different variants, and they found in their UK study that with the predominantly UK variant, or at least half of was the UK variant, that they had 89% efficacy. So very high effectiveness, even when about half of the viruses they identified were the UK variant. They had a much smaller study that they did in South Africa. That's a phase 2B study, and they did find somewhat reduced efficacy in South Africa where that South African variant was circulated. So we'll be waiting on the additional data coming from the U.S. and Mexico, but overall finding some efficacy even against the South African variant for this Novavax vaccine, which is still under development. Next slide. And then at the ACIP meeting, they did also have a presentation by AstraZeneca about their adenovirus-based vaccine. They did provide some information on efficacy as well. So it's not clear exactly when we'll have an FDA meeting about this vaccine, but one thing to look forward to is that it is stored at 2 to 8 degrees Celsius, so refrigerator temperature, for up to 6 months. So that definitely helps with some of the logistical issues with vaccination. And it's 2 doses, 28 days apart. They are in the phase 3 study in the U.S., and that study is fully enrolled. So we would expect some more information on the AstraZeneca vaccine, hopefully here relatively soon. Next slide. At the ACIP meeting, they also provide an update on vaccine safety. There are multiple different systems that CDC is looking at to monitor safety, and what they found generally is quite reassuring, and that the adverse reactions that they're seeing are very similar to what was found in the clinical trials. CDC also noted that they have over 200 pregnant women who are now included in the pregnancy registry, so that will help us get some additional information on these vaccines in pregnancy. And they provided an update report on anaphylaxis. Next slide. And what they found is that, again, most people who received the vaccine thus far have been healthcare workers. Most of the cases of anaphylaxis were among women, which was interesting. And the majority of the cases, again, did occur within that time frame for which we asked people to wait after getting their vaccination. So 90% of the cases of anaphylaxis occurred within that 30-minute time frame. And about 80% of people had a history of allergies or allergic reactions. About 24% had a history of prior anaphylaxis. And because most people have only gotten one dose who've been vaccinated, most of the information is about dose 1. Next slide. And so in summary, they found that the estimate for anaphylaxis for the Pfizer vaccine was about 5 cases per million doses administered. And for Moderna, it was about 2.8 cases per million doses administered. So that is very uncommon, maybe slightly higher from what we expect from some prior vaccines, which is about 1.3 per million, but still relatively low. So I think that's my last slide. I'll stop there.
Thank you so much, Carolyn. I appreciate those great slides. We had some questions come. We're going to get to those. I want to hear from Shelley and Rhonda first, but we have a couple great questions that came from that content. So thank you so much, Carolyn. Stand by. Let's go ahead and go over to Rhonda and Shelley, again from Albany Area Health Center in Albany, Georgia. I think we'll start with Rhonda to just talk about what you all have been doing with the COVID-19 vaccine in your community. Rhonda?
Okay, hi, great. So we are a community health center in Albany, Georgia. We have about 26, 27 sites throughout the Albany area, as well as some of the rural areas outlying Albany. So we started our vaccinations. We just chose 2 of our larger clinics to start. You know, vaccine distribution with COVID was new to all of us. So probably the biggest thing was getting everyone trained. There was some really great training on the CDC website, which is what we used as a guideline for our training process. We started with 2 clinics, and we started with about 600 doses at each clinic, 300 doses at each clinic, a total of 600 doses. We started with 2 distribution sites. We were able to vaccinate about 50 to 60 patients per day at each site. That's utilizing 1 nurse and a medical assistant. At the time, there was a lot of confusion about whether medical assistants could administer the vaccine, and most of our clinics are staffed 80% with medical assistants. So that was one barrier that we faced early on. But we were able to get staff to just do vaccines. We had all that nurse did was vaccines all day long. Like I said, we were able to do 50 or 60 a day. The issue we ran into is that our clinics have large volumes. So we see about well over 100 patients in clinic, and we were also bringing in that traffic for the vaccines. And we quickly realized that we were not able to maintain social distancing and do all the things that we know we needed to do and administer those vaccines. So Shelley began to reach out. I think that's one of the biggest things that have helped us be successful is utilizing the resources in our community. We utilized Phoebe Health System. They're a large community hospital in our community. We also have collaborated with Department of Health. Phoebe was able to loan us a much larger space that we could utilize just for vaccines, and we're in that space now. We have 9 vaccine stations, and our complete operations are now utilized through volunteers. We have retired physicians, retired nurses that have stepped in and volunteered to vaccinate. We've also utilized volunteers to do grits entry, which was another barrier that we found. We were able to give the vaccines, but data entry was a real barrier for us. And so utilizing the volunteers, we've been able to move the lines pretty quickly. In our current space, we're vaccinating over 250 patients a day. We've also done one mass vaccination clinic where we vaccinated 450 patients in less than 8 hours. And we actually did that on the 18th of January. But the biggest thing that I can tell you that we've done, that we've seen that works well, is utilizing the resources in your county. We've borrowed vaccines from Phoebe. We've gotten vaccines from DPH. Just reaching out and establishing those relationships with the people and the other companies in your county, it has been the most helpful. And reaching out to those volunteers, they have really helped us not be able to pull so much staff out of our clinics to help run our distribution site. And that's about all I can tell you that we've done thus far that has worked for us, that we've been able to vaccinate so many patients.
Thank you, Rhonda. Shelley, what else to add?
Sorry, had to unmute myself. I would agree with Rhonda. I think, if I'm not mistaken, we have administered over 3,000 or right at 3,000 vaccines. And as we continue to stress the importance of relationships, we can't continue to address health disparities by operating in a silo. And so those partnerships are truly key. And, we're just so fortunate that with our local hospital, a 450-bed hospital here in Albany, we have that relationship. We're very fortunate to also have the relationship with our Department of Public Health here, our health department. And those opportunities there have worked really well. If you expand it a little bit, I go on to talk about our relationship with AHEC, our Area Health Education Center, because the person who's helping me manage my volunteers is a retiree from AHEC as the executive director. And so she understands community health centers. She knows what we do. She knows people, and she reached out and started soliciting volunteers. And to be quite honest, we could not do what we're doing without the help of the volunteers. So being a community health center, I get it. We don't have the funds that some of these larger health systems have to be able to hire additional staff, have additional resources just at hand when we need them. So my philosophy is where there's a will, there's a way. And if we have the will to get this done, we will figure out the way. And so that's where a lot of this has come from. We get to a point that we're down vaccines, and I'm just like, oh my gosh, what are we going to do? And I thought, well, all they can do is say no. So I called some of my fellow partners and look, if we transfer vaccines within the system, is that one, accurate? Can we do it? And two, do you have some to spare, to loan? And so we borrowed some vaccines just to put on some of those events that Rhonda discussed earlier. And, it's also understanding, that sometimes we have to adhere to the community's needs as a federally qualified health center. That's what we do. And we are generally closed as a holiday, have been since I've been here 20 years, for Martin Luther King Observant Day. And so I decided that we're going to open. We're going to open one clinic. We're going to get some volunteers, and we're going to have a mass vaccination clinic, and the goal is 500. And we hit 450. Those are the kind of things that, even with the volunteers, they were right there. The staff, they were right there. And I didn't have to ask twice. And so it's very nice to have such supportive support staff when I make a decision that fulfills some of the needs of the community, that they're right behind me. And that's, I'm very appreciative of that. So it's been nice. So I would encourage, reach out to some of your partners, determine where that relationship can go and how to expand on it so that we can get more people vaccinated quicker.
Wonderful messages, both Shelley and Rhonda and Carolyn. Really appreciate. There's so much hope. during these sessions, so I appreciate that. We have about 3 questions. We have about 10 minutes, so I think we can get to them. We'll see if any more come in. The first one is actually about, this is from my health center that said, we just had our first vaccine clinic for COVID-19 for staff, and they were surprised to realize that there are reactions to the vaccine that are not anaphylaxis. So I actually asked for some specification. It looked like some migraine-like reactions and then an itchy throat. So the question that I'd like to pose this to all of our presenters is how to best manage those reactions both in real time and then also if, when you're planning for the second dose. Is there any guidance, you would have on that, about those kind of minor reactions, but definitely still significant enough?
Well, I'm not clinical, so I'll let the clinical go after I tell you my personal experience. I had that. I have completed my series, so I am so excited to be well on my way of 94% effective with my efficacy rate. But I had those same symptoms with my first dose, and it was basically probably 48 hours, and I took Tylenol, and it was just like as fast as it come on, it cut off just that fast. So within 48 hours, I was good to go again. I think that those are to be expected. We're all different. My colleagues around me had no issues. Got the same shot, around the same age group. Genders were different, same as me, some different. They had no reaction. And so I think it's just a matter of explaining how we're all made up different and that it's going to affect us all in different ways. But I'll let Rhonda explain from the clinical
Sure.
perspective.
Yeah, so out of the 3,000 vaccines that we've administered, I've only witnessed one reaction, and it was not anaphylactic. He actually just, time he got the vaccine, he just turned white, like paper white. His arm turned red, not at the injection site, but the lower part of his arm. Never seen that happen. We just monitored him. It was nothing that required any treatment. We did monitor his blood pressure, and it took about 15 minutes, and he was fine. I followed up with him the next day. He was doing fine. He was actually very young. He was probably 30, 31. Other than that, I've had some patients that had the expected symptoms, like what Shelley was talking about, but we've not had any anaphylactic reactions. But from a clinical standpoint, one thing that I did do is when we were in the clinics administering the vaccine, that was a little bit different. We had a provider there. We have a crash cart. We have protocols in place. The distribution center that we have now is off-site. So one of the things that I have just been really adamant about is having well-defined policies and procedures for how to manage any type of reactions. Luckily, the center that we're at now is connected to an urgent care center. So we do have some backup and some reinforcement, but I think that's the piece that we sometimes miss is how to manage those anaphylactic reactions and make sure that our staff are prepared to deal with those in the event that they happen. And the more vaccines that you give, your chances of experiencing that are going to be greater. So just making sure your staff is prepared, I think is the only thing you can really do.
Great. And actually one of our, someone came in with their own answer about, they said, we have second doses Friday. We tried to schedule on a Friday to have the weekend to recover. So that may be a great best practice, is stagger, much like, staggering those staff doses is staggering those second doses too. Great. No, thank you. And thanks for sharing your own experience, Shelley. That's always good to hear. Another question is, and I'll actually pose this to Carolyn first, is that vaccinating pregnant patients, CDC says one thing and the World Health Organization says another. So World Health Organization is not recommending it. CDC is recommending it. I know you are not a representative of either entity, but any thoughts on that? Or we can, any thoughts on that?
Yeah, thanks, Sarah. It definitely can be confusing, and people are getting a lot of different information. But, ACOG also has some very clear statements up on their website as well that you can refer people to, as well as CDC information. And as I mentioned, there is more information that's being collected through pregnancy registries. Many healthcare personnel who are pregnant chose to get vaccinated, and there'll be additional safety data that becomes available. So, yeah, it's tough when there's competing statements.
Yeah. No, thank you for that answer. Another one, switching gears actually over to flu. Remember, it's still flu season, and we're still pushing flu vaccine. So I wonder, and actually, if I can start back with you, Carolyn, on this. So many resources that your organization gives are on flu. What do you feel right now is kind of the lay of the land with flu? Should we keep promoting it? Is it the forgotten vaccine? Or what are some best practices to keep promoting the use of the flu vaccine as well?
Well, we're just not seeing much influenza. I mean, the surveillance data shows very, very little influenza circulating in the U.S. And given that we need to make sure that people have at least 2 weeks between any other vaccine and COVID-19 vaccine, and our staff, as you've just heard from Albany, they're really busy. This is a all hands on deck effort for COVID-19 vaccine. That I'm not sure that the priority at this point is influenza vaccine, but we do need to remember for the fall that there are many parts of the world where they weren't really able to socially distance necessarily, where flu viruses are still circulating, and any of these vaccine preventable diseases are just an airplane ride away. So we should still be thinking about what we're going to be doing, getting ready for next fall.
Great. Rhonda or Shelley, what's your take on flu vaccine right now? Is it still being given at your organization? Are you still focusing some on it?
We are. We actually had this discussion. We monitor and track our flu vaccines monthly at our QI level, and continuing to watch and figure out, try to determine why either numbers are down or stagnant, why aren't they going up, so we can determine flu campaigns, mass communication, so that people still know that the flu still exists, and we still need to combat it as well. But Rhonda it'll segue into Rhonda, but we were talking about this, and it's that 14 days of your last injection for most of our people, because they want to go ahead and get the COVID vaccine first. Yep. And so we're seeing a lot of people wanting to wait till after that second dose, so it doesn't interfere with them being able to get their vaccine. Rhonda, you have some stuff to add?
No, that's about what we've been doing. We are down quite a bit, and to be honest with you, a lot of effort has been put forward toward the COVID vaccine. That's all, that's all people see now. They see it on TV. I mean, it's everywhere. So that's been the vaccine that people have wanted to get, and we still do encourage our patients on their visits to get their flu vaccine.
Yeah. Great. As we focused a lot on flu vaccine before COVID-19 came out on this webinar, and just as another plug, there are free flu doses for community health centers that are definitely still available. So I encourage any health center that's listening on this webinar, if you are out of flu vaccine or you're running low on flu vaccine, to contact your local health department and ask for access to those. The CDC had put out 9.3 million free flu doses for all jurisdictions for any healthcare provider. So we encourage you to keep doing that. We are out of time. It's 12:30. It always goes so fast. So I want to thank especially our panelists today, Carolyn and Shelley and Rhonda. Thank you so much. I wish we had longer and could hear from you longer. But thank you so much for all the things that you are doing, as well as taking the time today for that. Like I said, we have no more FDA sessions coming up, but we will continue to share resources. We have a newsletter coming out that is on our NAC COVID-19 page. So if you go to nachc.org, we have all things COVID-19 page with some great information on that. We have a microplanning document that's on there that is proving to be useful, that kind of summarizes some of the things that we've learned on these. Anytime if there's any additional questions or any follow-up, I can certainly be in contact to triage those. Again, my name is Sarah Price. You can email sprice@nacc.org. Thank you again for your time today, and thank you to our health centers. You all are doing such strong work in such difficult times. So thank you. Have a great weekend, everybody.